Can you achieve a healthy pregnancy with PCOD? And if you do conceive, what are the risks that you need to worry about? In this video, I will tell you what a pregnancy with PCOD looks like, how to manage PCOD pregnancy. Many women with PCOD conceive naturally, but a small mistake, sometimes a small carelessness or unawareness about many things causes either a miscarriage or diabetes in pregnancy and many other complications. Watch this video till the end. Hi, I'm Dr. Rajat, and through my years of managing patients of pregnancy, in this video, I'll tell you everything about PCOD, what works for PCOD, what works in pregnancy with PCOD, what precautions you need to take. By the end of this video, I promise you will know how you should manage a patient of pregnancy with PCOD, what are the diet and the lifestyle modifications, what are the medicines, what are the need of insulin, what are the possible complications, and what do you need to do to achieve a healthy mother and a healthy baby. Hello, I'm Dr. Rajat, and you have started watching our YouTube channel, The Gynec, Fertility Gynecologist. Just for your information, PCOD and PCOS is an intermingling term. PCOS is a polycystic ovarian syndrome. PCOD is a polycystic ovarian disease. PCOD mainly concentrates about the gynec and the reproductive aspects, while polycystic ovarian syndrome concentrates on the metabolic aspects also. And just quite recently, PCOD has been rechristened, renamed as PMOS, polyendocrine metabolic ovarian syndrome. I'll not go into the details, but according to the Rotterdam criteria, PCOD has been characterized into various phenotypes. Phenotype A contains hyperandrogenism, oligo or anovulation, and polycystic ovarian morphology on ultrasound. Phenotype B contains oligoanovulation with hyperandrogenism. Phenotype C contains hyperandrogenism with polycystic ovarian morphology on ultrasound. And phenotype D contains oligoanovulation and PCO morphology. Now, main aim of segregating PCO patients into these phenotypes is because most of the patients directly come and tell us that PCO hai, PCO hai. To do this, PCO is a heterogeneous disorder. It is a genetic disorder with epigenetic changes, and it is exacerbated by lifestyle and adiposity. The main pathology of PCO is PCOD, PCOS or PMOS, whatever you call, is hyperandrogenemia, insulin resistance, which ultimately leads to hyperinsulinemia, which causes most of the problems. Some females have got more hyperandrogenism, some females have got more polycystic ovarian morphology, some females have got oligoanovulation, or some females have got everything. You cannot just label a female patient a polycystic ovary just by looking at polycystic ovarian morphology on ultrasound. There has to be a fixed criteria for that. And the most important thing, as far as I am concerned, is insulin resistance, which leads to hyperinsulinemia. This hyperinsulinemia leads to an increase in the androgen. Androgen leads to the symptoms of acne, it leads to the symptoms of oligoanovulation, it leads to the symptoms of male pattern baldness or alopecia or hirsutism, all these kind of things. And insulin resistance and hyperinsulinemia, since it is a growth hormone, it also leads to the obesity. So it is a vicious trap and a vicious cycle. Why I am worried and why I have chosen this topic today: women with PCOD, once they conceive, that comes in a high risk pregnancy. In early pregnancy, there are increased chances of miscarriage. In later pregnancy, there are an increase in chances of gestational diabetes mellitus. Even the preeclampsia, the blood pressure in pregnancy increases, and sometimes it so happens that there are chances of preterm labor. Either preterm labor occurs on its own or because of severe blood pressure or severe preeclampsia or severe hypertension or severe diabetes mellitus, we have to terminate the pregnancy. The problems with PCOD occur even after the delivery. There are increased chances of postpartum depression. There are increasing chances of cardiovascular complications. There may be also difficulty in breastfeeding. So PCOD pregnancy has to be managed individually. There has to be a tailored regimen. First and foremost thing is you have to optimize your health, especially before you conceive. By optimizing, I mean the diet and lifestyle modification should be there. I'll come to it in the later part of the video. But the diet, there should be modest pre-pregnancy weight loss with moderate physical activity and consumption of a healthy diet. Obesity is one of the known high-risk factors for complications in PCOD. Most of the Indian families, especially parents, believe that mother should eat for 2 people, and the moment a female conceives, they start feeding, overfeeding, and excess feeding to her. They say, "Bacche ke liye khana hai, bacche ke liye khana hai," when this is not the case. Actually, according to the National Association of Medicine guidelines, the weight gain in pregnancy should be limited and is dependent upon the baseline base body metabolic index at the time of conception. If body metabolic index, basal metabolic index is more at the time of conception, then the weight gain should be less. And if body basal metabolic index is less at the time of conception, the weight gain should be more. If BMI is between 18, less than 18, then the body weight gain should be about 12 to 18 kgs in pregnancy. If BMI is between 18 to 24, the weight gain should be 11 to 16. If it is overweight, that is more than 25 BMI, 25 to 29, the weight gain should be only between 7 to 11 kgs. And if BMI is more than 30, this is where most of the polycystic ovarian disease PCOD patients lie. The weight gain should only be between 5 to 9 kgs. Please remember, most of the parents, most of the common people think that the weight gain in pregnancy reflects the weight of baby, when it is actually not. In PCOD patients, in PCOS patients, already there are increase in inflammatory markers in pregnancy, and that may lead to increased chances of blood pressure rise, increased chances of gestational diabetes mellitus, and if weight gain is not controlled, then the catastrophic complications can occur. These PCOD complications, they can be compensated by a healthy diet and a good lifestyle. By healthy diet, I mean that there should be an optimal intake of the core food groups. Please remember, for core food groups, I mean wholesome foods, cereals, milk, poultry, fruit, meat, and dairy items. And there should be limited or no intake of a discretionary, that is non-core fruits, which include sugar, salt, saturated fats, and energy. If I talk in the basic terms, I always tell my patients to avoid 4 foods. There should be no sugar. God has not made us to eat sugar. If you want to eat sugar, you can eat fruits, but that should be also in limited quantity. That should be preferably in the first half of the morning, and those fruits should also be of low glycemic index. High glycemic index food should be avoided. Number 2, you should eat and avoid anything which has got refined carbohydrates like potato, refined carbohydrates like fine flour, that is maida, anything made from maida, toast, biscuit, pizza, pani puri, samosa, farsan, maggi, pastry, cake, bread, pasta, burger, noodles should be absolutely no. And I am a firm believer in gluten intolerance. It leads to many issues, triggers many autoimmune disorders. So I also believe, and I advise my patients to avoid wheat roti instead of having millets, jowar, bajri, makai, ragi, quinoa, and all those kind of things. And any fruit juice should be avoided, any cold drink should be avoided, any ice cream, desserts should be avoided. You should concentrate on the nutrient dense food. There should be dry fruits can be taken. You can take fruits, but like I mentioned, about 500 to 700 grams fruits per day. Not single fruit should be 500, 700 grams. There should be multiple fruits, say 1 slice of mango, 1 slice of banana, half apple, 1 kiwi, few grapes, half a chiku, all these kind of things. There should be an assortment of various fruits. Fruit should be preferably taken in the morning along with breakfast or with lunch. You can have fruits as your desserts. Try and avoid fruits in the second half of the day. The complications of PCOD pregnancy. One of the most common complications of a PCOD pregnancy is a miscarriage. Increased age is an increased risk factor for a miscarriage. Increased weight, obese patients are again at the risk of miscarriage. If insulin resistance is more and there is an hyperandrogenemia, there is more male hormone, testosterone hormone, it also increases the risk of the miscarriage. And all these factors, apart from age, obesity, insulin resistance, and hyperandrogenemia, are controllable risk factors, modifiable risk factors. With a good lifestyle, with a good diet, they can be very well controlled and kept in check, especially pre-pregnancy. There is also increase in the risk of gestational diabetes mellitus. Again, like I mentioned, the risk is more in second half of the pregnancy. Risk is more in females who are elderly. Risk is more in females who have got increase in baseline weight, that is in obese females, and females with hyperandrogenemia or high insulin resistance positive. Normally, I get a test of an insulin resistance that is called as HOMA index. Few people get glucose tolerance test done, few people get HbA1c done, but I, before pregnancy, get HOMA index test done, that is fasting insulin and fasting blood sugar done, and that ratio tells me whether this patient is insulin resistant or not. If insulin resistant is there, depending upon the degree of insulin resistance, I start the tablets. There is also an increased risk of increase in blood pressure, hypertensive disorders in pregnancy in the second half of pregnancy. There is also an increased risk of preterm deliveries. This preterm delivery is because of an apparent endometrial abnormality, and these endometrial abnormalities are because of the hyperandrogenism. Same hyperandrogenism causes endometrial abnormalities, which may lead to a increase in risk of a miscarriage. So ultimately, you need to decrease androgen for androgen, because this androgen is increase because of insulin resistance, you need to decrease the insulin, and to decrease the insulin, you need to control your sugar spikes in your body, and these sugar spikes in the body can be controlled by eating complex carbohydrate rather than refined carbohydrate. And this complex carbohydrates has to be taken along with fiber, along with vitamin C, along with protein to delay the increase in the sugar peak. Whenever we eat any food in the body, the glucose increases. That food is ultimately converted into the glucose in the body. And the more the glycemic index of the food is, the more faster the glucose and higher the glucose will rise. To control that glucose rise, the body will start secreting insulin after 45 minutes to 1 hour after the glucose rise. The more glucose rises, the more insulin rises. If this cycle continues, after one point of time, insulin would stop acting. The function of insulin is to put the glucose back into the cells. From an extracellular glucose, it takes intracellular for the energy of the cell. The moment insulin stops acting, it is called as insulin resistance. Body secretes still more insulin, and that is called as an hyperinsulinemia. Hyperinsulin is a growth hormone. By growth hormone, I mean it is lipogenesis. It converts the excess of glucose into the fat, and that is where the weight gain occurs. And this excess fat is stored in the belly, in the abdomen, in the stomach part, and that adipose tissue is a hotbed of an inflammation. It releases various cytokines, and almost all the disorders, especially preeclampsia, blood pressure, or miscarriage, or preterm labor, are because of the inflammation. So we need to control that inflammation, and to control that inflammation, we have to control the basic step of taking the glucose inside our body. So the question is how to manage a PCOD case with pregnancy. First and foremost thing is diet. Your diet should contain plenty of fiber, plenty of protein, and carbohydrate should be less in quantity. It should be complex carbohydrate, which is the one which is found in vegetables, the one which is found in whole grains. By whole grains, I mean millets, bajra, jowar, makai, ragi, quinoa. The flour should not be very finely grounded. It should be slightly coarse. Along with that, if you take protein along with carbohydrates, if you take fibers along with carbohydrates, what it will do, it will decrease the glycemic index overall of the food. If the glycemic index decreases, the overall increase in the glucose which occurs after eating would decrease. As a result, the body would secrete less insulin, and over a period of time, the insulin resistance would decrease. So you need to take a balanced diet which contains whole fibers, proteins, and healthy fats. Please remember, fats is very important. I always tell my patients, desi ghee is wonderful. Fats do not make you fat. It is the carbohydrate which makes you fat. You need to understand the biochemistry. Excess of carbohydrates are converted into the fat as a storage. If we do not take excess carbohydrates, then our body starts using the fat from our body stores, and as a result, our body fat decreases. We should aim to achieve a 30 to 30% calorie restriction, calorie deficit. That means approximately 500 to 700 calories should be taken during the day. And I always tell my patients, your meal should not be heavy. Your meal should be very light. It should be containing, especially dinner. Dinner should not contain carbohydrates. If it contains carbohydrates, it should not contain any carbohydrates. If it must, then there should be either roti or chawal, not both. Roti should not contain wheat. And even in the carbohydrate, you should be having a portion control, should be very, very important. Say if you're eating 200 grams of chawal, instead of taking 200 grams of chawal, divide it into 3 parts. Take 1 part chawal, 1 part dal, or any kind of sprouts, vegetables. It can be chola, chana, rajma, tuver, anything. And rest 30-40% should be fiber or green leafy vegetables. It can be anything. It can be radish, it can be carrot, it can be any green leafy vegetables. So you have protein, you have fiber, and you have carbohydrate. Put it along with that, add some vinegar or add some lemon juice, and it will decrease the glycemic index of your food. This is what you should do for meals. Apart from that, you should also concentrate on at least 30 to 40 minutes of walking, especially after meals. I have made a video of post-parental walking, post-eating walking. This is the most wonderful tool to control insulin resistance, to control the sugar spikes. At the moment you have finished your meal, start walking. Walking as less as 2 minutes would start doing benefits. But if you want to have an ideal minimal benefits, you should walk for at least 10 minutes. If you want to have optimal and a good benefits, you should walk for at least 15 to 20 minutes. That walk should be not very fast. That walk should be not power walking. You should walk gently. The basic premise of walking after meals is the moment you start eating, your glucose starts rising. Glucose reaches peak at about 45-50 minutes. Before the glucose reaches peak and before the peak of the glucose, body starts secreting insulin. You have to start walking before the glucose reaches its peak, so that whatever glucose is there in the blood, that will be diverted to the muscles, because muscles utilize glucose as a fuel for work. So ultimately, if you walk for say about 15-20 minutes, that means approximately 2 to 3 kilometers, you will be utilizing approximately 200 to 250 calories for walking. And that much sugar would be utilized. So ultimately, your blood sugar would be less, your blood sugar control would be more, you would be having less of the problems. You should be smart in utilizing your strategies. By smart, I mean, as for specific, you should be very specific what you should eat, what you should do. Your activities should be measurable. How much you walk, how much you eat, when you eat, they should be achievable. You should not have a goal that you cannot achieve. You cannot go for a 1 meal a day diet, or you cannot go on an intermittent fasting in pregnancy. They should also be realistic. In pregnancy, you cannot go for fasting completely. In pregnancy, you cannot go for swimming, jogging. You cannot go for power sprinting. You cannot do a high intensity interval training. You cannot do gym. I normally do not advise. So they should be realistic and they should be timely. It is not that I'll do after my pregnancy is over or I'll do later on. You should do it daily. You should do it timely. Portion control is very, very important. You should control the amount you should eat. You can increase the volume by having 0 calories items in it. You can add radish, you can add carrot, you can add cucumber, you can add beetroot, you can have chanas, peas, whatever you like. You can have buttermilk to fill your stomach, but the amount of calories should be less. You should be eating mindfully. Now, what I mean by mindful, I'll make a separate video on a mindful eating. In last approximately 15-20 years, we people have started eating very much, and we have a habit of either scrolling our phone or watching the TV while we are eating. We have been given 32 teeth, and our ancestors and grandfathers used to tell us every bite which we take in our mouth has to be chewed for 32 times minimum. Once when you chew 32 times in your mouth, the process of digestion of food starts in the mouth, because your saliva mixes with the food and a solid food is converted into a semi-solid paste-like food which goes into the stomach for digestion. And the moment you do a mindful eating, automatically, if you're habituated to eating 3 rotis or 4 rotis, you will only eat half of that quantity, because you will be full. Your hunger would be full. You will have a satiety sensation relatively early. What we people are doing, take a bite, chew once, chew twice, chew thrice, chew 4 times, maybe 5 times, and then we swallow. What happens in that process is half semi-digested food is going into the stomach. Once the semi-digested food is going into the stomach perceives that more amount of food is there, so more acid is secreted in the body, and we end up in problems of gas, acidity, indigestion, and all those kind of things. And also, since the more we eat, more it is absorbed, we tend to eat more. So if we do a mindful eating, we need to enjoy every bite. We need to focus on every bite. We need to believe that this food is giving us energy. Most of people, we live to eat. We have to eat for living. Please remember, जीने के लिए खाना है, खाने के लिए नहीं जीना है. If we are eating something which we like, we'll have 2 extra chapatis, we will have extra vegetables, we will have extra desserts. Please do not do it. Your body always gives you a signal when you are full. If you have eaten 2 rotis, you will have some kind of a belching. That is a signal that you are full. We almost tend to overfill. There is a difference between hunger and satiety. The moment you have a slight sensation of belching, that means you are full. But we eat up to here. We eat up to satiety. And that is what causes problems. In pregnancy, we do 75 gram glucose oral glucose tolerance test. That is done at 20 weeks and 24 weeks and 28 weeks. I normally, instead of doing glucose oral tolerance, I just do repeat HbA1c every monthly. If PCOD patients was on metformin, I continue that metformin till delivery. If the HbA1c is more than 6.5, suppose PCOD patient was already on metformin or minoxidil, and if that patient at the time of conception has got HbA1c which is more than 6.5, I start insulin in consultation with physicians. I do not keep the patient on metformin. I start insulin because, according to me, in pregnancy, because of various factors, because of vomiting, nausea, because of gas, acidity, patients are very finicky. On the top of the that metformin causes gastrointestinal disturbances. So blood sugar control is not there, and if strict blood sugar control is not there, especially in first trimester of pregnancy, it can lead to miscarriages. It can lead to the congenital malformations in the child. Uncontrolled diabetes mellitus or excess of HbA1c is known to cause the congenital malformations in child. So I start insulin. But if HbA1c is normal, around 6, less than 6.5, I keep continuing metformin. I repeat HbA1c every weekly, and my threshold is 6.5. I repeat HbA1c every monthly, and my threshold is 6.5. If HbA1c crosses 6.5, I, in consultation with my physician friends, start the patient on an insulin. That insulin has to be continued till delivery, and it gives me a wonderful results. Why I am worried about insulin? I have seen patients, especially in the second half of the pregnancy, even if they are on metformin, even if the blood sugar is well controlled, there can be sudden unexplained intrauterine fetal death. It can be because of various factors, and that cannot be predicted by a use of a NSD or a Doppler. And I have found in my practice that using insulin, especially for patients who have got high HbA1c, works better. I ask my physician friends to start at a minimal dose, 4 units, 3 times a day, or 6 units, whatever, according to the weight and according to their sliding scale. But starting an insulin is a very, very important necessity, especially if the patient has got high weight before pregnancy, especially if patient has got hypertension in pregnancy. Even these patients postpartum have got increase in chances of cardiovascular risk complications during pregnancy. 35 minutes of walk needs to be encouraged. Gym should not be encouraged. Jogging, swimming, dancing should not be encouraged. Simple, plain walk post meals along with a good dietary control. And I always tell my patients, eat nutrient dense foods so that the amount is less, but you'll have, say, 2 walnuts, 2 almonds. They'll give you enough omega-3 fatty acid. You don't need to take extra supplements. They'll also have enough amount of proteins in the body. In conclusion, I would like to say, PCOD is a heterogeneous disorder. Although it is a genetic disorder, but it is modifiable by epigenetics. By epigenetics, I mean lifestyle and diet. In almost 100% of the cases, PCOD can be managed optimally with a healthy lifestyle and healthy diet. Only thing is we need to make change here. We need to shut our mouth for eating, and we need to start using our legs for walking. Human beings have been programmed to walk for 20 kilometers a day. We do not even walk for a couple of kilometers a day. And we human beings have a tendency to overestimate the amount of physical work we do and underestimate the amount of eating we do. We just have to reverse. We have to eat less and walk more. During pregnancy, the complications are higher. So you should, once you conceive, you should not think that now I have conceived, now the pregnancy will go well. The real problem, real challenge of pregnancy starts in a PCOD case once when you conceive. There are maybe increased chances of miscarriage. So you need to be extra careful of diet and lifestyle once when you conceive. Yes, before conception, you can do gym, exercises, hard work, but after conception, these are not advisable. So diet is a very, very important part. Bariatric surgery has got a definite role in PCOD in extreme obese patient, but that is not in pregnancy, that is before pregnancy. And even if the bariatric surgery is done for a weight loss, we have to wait for at least 1 year before the patient conceives because of the micronutrient deficiencies which occur as a result of a bariatric surgery. Hope you like this video. Please share the video. Please subscribe to our channel. Namaskar. Bye-bye.